with the heart. This is part 2 of 3 series. Now I did forget to tell you about the total heart block. That's caused if there's damage to the AV nodes. We're not going to have any signals from the atria, which will not get to the ventricles. And of course, if there's no signals to the ventricles, beats, the rhythm, or minimal signals to the ventricles, the heart rate is going to slow down to approximately 20 to 40 beats per minute. So let's look at the SA node. The cell of the SA node do not have a stable resting potential. Instead, the membrane potential starts at about 60 millivolts and drifts upward in a gradual depolarization called a pacemaker potential. Now the slow drift results from a very slow influx of sodium without a compensating outflow of potassium. So now we're having sodium being pushed in, but then we don't have enough potassium coming out. Okay, so when the pacemaker potential reaches approximately 140 millivolts, the voltage regulated fast calcium sodium channels, they begin to open, and then both of the ions in the extracellular fluid, they're going to flow in. Now this produces the rising phase of this action potential. So let me see if I can get to that slide for you guys. You get a visual. Here we go. A visual of what is actually occurring. So here we're starting off, the resting membrane potential is negative 60 millivolts. So when we have a very slow increase or influx of sodium ions entering into the intracellular fluid, into the intercellular space, we have an increase. Now don't forget, we don't have sodium pumping out. We have a little bit of sodium pumping out, but not enough to accommodate the increase of sodium entering in. So when this action potential or the pacemaker potential reaches a negative 40 millivolts, this is when the calcium sodium channels begin to open. And then both of the ions from the extracellular fluid are going to enter in. So we have an influx of both sodium and calcium. Now at this point, those calcium channels are going to open, and they're going to let these calcium channels out of the cell, and that's going to help repolarize it. So that's bringing it back down to the normal state. Now the calcium channels are then going to close, and the cycle will start again. Now each depolarization of the SA node starts off one heartbeat. Now at rest, the SA node typically fires every 0.8 seconds or so, or 75 beats per minute. So I'm going to see if I can post a video for you guys just to go over this, to give you guys a visual, because I like those other videos where you can actually see the channels opening and the ions passing in and out of the cell. So make sure you take a look at that. Now impulse conduction to the myocardium begins with when the SA node fires. Now firing on the SA node excites the atriocardiocytes, stimulating the atrial contraction. So when the SA node starts to fire, it's going to fire the cells in the atria. And it's going to stimulate the atria. Those cells are going to stimulate the atria to start contraction. That's going to start squeezing and contraction and pushing that blood down towards the ventricles. Now the signal travels at 1 meter per second through the atrial myocardium, and it reaches the AV node in about 50 milliseconds, meters per second. Now in the AV node, the signal slows down to about 0.05 millimeters per second. Now this slowing is primarily due to fewer gaps in the cardiocytes in this particular region. Now why is there a particular delay? There's a signal delay of about 100 meters per second. And why does this occur? From the atrium to the ventricles, why is there a slight delay? And that delay is to give the ventricles enough time to fill. Now the ventricular myocardium has a conduction speed of only, let's try that again. I think this is where I am. Yes, it is. Okay. So the ventricular myocardium has a conduction speed of only 0.3 to 0.5 meters per second, but signals travel through the AV bundle and the Purkinje fibers at a speed of 4 meters per second. As a result, the entire ventricular myocardium depolarizes within 20 meters per second after the SA node fires, causing contraction of the ventricles in near unison. Now signals reach the papillary muscles before the rest of the myocardium, so that these take up slack in the tendinous cords in an instant before the ventricular contraction. Remember we talked about the tendinous cords? Those are those cords that are keeping the AV nodes, the AV valves attached or anchored to the ventricle walls. So they have to loosen up first before the contraction starts, otherwise they may snap. Now ventricles systole begins at the apex of the heart and moves downward, pushing blood towards the semilunar valves. So it starts a little bit higher up. The contraction doesn't start from the apex and then it's going to squeeze from the bottom up. It starts from the top part of the ventricles and then downward to the apex and for that contraction to occur. Now the action potentials of the cardiocytes are significantly different from those of the neurons of the skeletal muscle. Now cardiocytes have a stable resting point of negative 60, negative 90. Okay, I'm going to start this slide again because I don't remember where I stopped. The cardiocytes have a stable resting potential of negative 90 millivolts, and normally depolarize only when stimulated until SA node cells. Unlike the SA node cells, I think I did this slide already. Hold on one second. Okay, I wanted to talk about this particular diagram here in figure 19.4. So me talking about the resting potential, we're talking about this particular slide, not the slide before, I'm sorry. So the resting potential is approximately at negative 90 millivolts and only depolarizes when it is stimulated, unlike the SA node cells. It's totally different. Now the stimulus, it will open the voltage regulated sodium gates, and it would allow the sodium to flow inward and then depolarize the cell to a threshold. Let me get this mouse working. Now this threshold voltage, it opens more sodium gates, and then it triggers a positive feedback cycle. Now the action potential peaks at positive 30 millivolts, and at which point the sodium gates, they will close. So here they're open because they're stimulated and it's at negative 90 millivolts. But then when they're stimulated, you have all of a number of the sodium channels or channel gates opening. And at this point, this is where they start to close and depolarize. Okay, and this is at positive 30 millivolts. Now, as action potential spreads over the membrane, they open voltage regulated slow calcium ions that emit calcium. Now, the calcium is going to bind to the ligand regulated calcium channels on the SR, the sarcoplasmic reticulum, opening them and then releasing the calcium from the SR. Now this wave, the second wave of calcium, it binds to the troponin, and it will trigger the contraction just in the skeletal muscle. The SR provides 90 to 98% of the calcium needed for myocardial infarction. Now, in the cardiac muscle, the depolarization is prolonged for 200 to 250 milliseconds, as compared to 2 milliseconds in the skeletal muscles and the neurons. Now, this long plateau in the action potential may result because of the calcium channels are slow to close, or because the SR is slow to remove the calcium. So that's at this point right here. Now, as long as the action potential is in its plateau, the cardiocytes contract. The cardiac muscle does not have the brief twitch of skeletal muscle, but a more sustained contraction of blood expulsion. So that's getting rid of the blood. So both atrial and ventricular cardiocytes exhibit plateaus, but they are more pronounced in the ventricles. So at the end of the plateau, calcium channels close. So now we're at number 5. The calcium channels are going to close, and the sodium channels are going to open, and the membrane voltage drops rapidly, and more muscle tension declines soon afterwards. So I'm going to see if I can find another video on this for you. With this for you guys, you guys look at what is going on with this type of behavior, the action potential of a myocardium. And here I put in the description of what is going on at the different stages. Your depolarization, that's it when it's increasing, the little line going up, and then that's from negative 90 to plus 30, and then our plateau is when it starts to level off, and then the repolarization phase is when it starts to drop. Okay, those three main phases of that particular diagram. So let's move on to our electrocardiogram. Now I added some extra slides talking about placement and what you're looking at when you look at an EKG, which is electrocardiogram. This is the placement of the leads. You have 12 leads. You have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Well, 10 to 12 leads. Before they used to have this one up here. They're all numbered, or they all have various labeling. But this is V1, used to be here, and now they've placed it on this side of the heart. So you have V1, V2, all the way to V6, and that's this one here. That's V1, 2, 3, 4, 5, and R6. and they all look at different angles of the heart. Okay? And they have different placements. So those going into nursing, you might need to keep this particular slide, or you can find some other stuff on the internet based on just EKG placement and how and what it's going to read, the directions of how it's going to read at the heart. And here we have the different leads. Like when you look at the EKG itself, you have various leads that you have to look at. You have your limb leads, and it'll be displayed, and with each little box here, you're going to have an EKG reading. It may not, and some of them may not look right or correct. They may look in, some of the things may look inverted, but it's just the angle at which you're looking at. So these are considered our limb leads, and these are our precordial leads. Now our 1, our 2, our 3, and our AVF, those look at the inferior part of the heart. So inferior, we know, is the bottom. And then we have this one here, our 1, our AVL, our V5 and 6, that looks at the lateral. So that's the sides of the heart. Now the anterior view will be our V3 and our V4. And then our septum, which remember we have 2 septums, our interatrial, our interventricular septum. Those are our V1 and our V2, and that looks at the septum itself. Because don't forget, we have the AV bundle and the AV node within those areas. So back to what the book talks about. We have our EKG machine, our ECG machine, and this is used to detect the heart's electrical current and produces a graph called an ECG EKG. And this is what it looks like. We have our P wave, our QRS, and then our T wave. Now when we look at the EKG, we have our P wave. Let me pull up everything for you guys so I don't forget. Alright, so the P wave is produced when a signal from the SA node spreads through the atria and depolarizes them. So basically we're looking at the contraction of our atria. Starting with the SA node, that's the atria here. Then the atrial systole begins about 100 milliseconds after the P wave begins. Now during the PQ segment, which is here, PQ segment, okay, this is occurring during this PR segment. This is our atrial asystole. So this is the firing of the SA node, and this is the atrial asystole from the P to the Q. Okay, now the QRX complex. So that's here, from here to here. This consists of a very small downward deflection, Q, which comes down, then a tall, sharp peak, R, and a final downward reflection of our S. And it is produced when the signal from the AV node spreads through the ventricular myocardium and it starts to depolarize the muscle. Its shape is due to the different sizes of the 2 ventricles and the different times required from them to depolarize. Now, atrial repolarization and diastole also occur during QRS interval, but the signal is obscured by ventricular activity. Now, our ventricular systole begins after the QRS complex, and that takes place in the ST segment. So our S and our T segment. This is when we have ventricular systole. So that's when the ventricles are contracting. It begins after the QRS complex in the ST segment. Now the ST segment corresponds to the plateau in the myocardial action potential and is the time during which ventricles contract and eject the blood. That's our ST segment. Now with our T wave, the ventricles take longer to repolarize than to depolarize. And so the T wave is smaller and more spread out than the QRS complex and is rounder. Even when the T wave is taller than the QRS complex, it can be recognized by its relatively rounder peak. Now there are times where there is a U involved in there, but we're not going to get into that. I know you may be wondering, why is there a U? But there is a slight U in a normal EKG. Sometimes it appears, sometimes it doesn't, but there is one. Okay. So here we have another diagram dealing with what happens with the ventricles and the atria. So in figure 1, we have the atria beginning to repolarize, to depolarize. So we're looking at the yellow portion. So that is, the ventricles are depolarizing. In 2, the atrial depolarization completes. So you see here what's happening here. The SA node is firing to both of the atria to the AV node. So now we're having the filling. Now it is filled. This is our depolarization is complete. In 2, we have the the ventricles begin to depolarize at the apex, and the atria start to relax. See, in the green means that they're relaxing, the red if we having the contraction. So that's forming our QR, and our RS is when the ventricles actually start to depolarize completely. So RQRS right before the T. In our number 5, here we have the ventricles that begin to repolarize at the apex. So that's when they're starting to relax at the apex. And in number 6, we have a complete relaxation or repolarization of the ventricles. Alright, now EKG is useful for diagnosing abnormalities in conduction pathways, myocardial infarction, enlargement of the heart, and any other electrolyte or hormonal imbalances. And this is what a few of them look like. This is a normal sinus rhythm for P, Q, R, S, and our T. It has a certain rhythm. Okay. Then we have our nodal sinus rhythm, but there's no SA node activity, so there won't be a P. We have our heart block, where you don't see a QRS. So remember we talked about heart blocks, where what did we say about heart blocks? If you don't remember, heart blocks is basically dealing with when the AV node is damaged. So you won't have signals from the atria fail to reach the ventricles. So that's why you don't have a QRS. You might have a little bit here, but then here it goes. So there's no QRS here, but you have it here. So you can tell that there is heart block. A heart block. It's not a total heart block, but there is partial heart blockage. Okay, so the heart rate will be a lot slower and irregular. Then you have preventricular contraction, where the ventricles are contracting a lot faster than it's supposed to, causing an inversion of our QRS. And then our squiggly line, which is our VFib, ventricular fibrillation. Okay. Here's what happens when here are a few structures that the book talks about with our RV, with our R wave or QRS when they are not normal, what it means. When the P wave, now each of these waves, the waves and the complexes, everybody in the segments, they have certain normal values. So if this P wave is enlarged, is a lot wider or taller, it means that the atrial has been enlarged. If the P wave is missing or upside down, that's what an inverted means. So let me get my pen out again. If the P wave looks like this, then we have our Q, R, S, R, T. This means, or if it's missing, not there at all, then the SA node is damaged. And the SA node the AV node has taken over the pacemaker role. Now, if we have two or more P's, so we have two P waves, and then our QRS, then we have heart blockage. Now, if we have extra or misshaped, sometimes inverted QRSs, so QRS is supposed to look like this. Sorry, let me erase that one. If our QRS is supposed to look, I did it again. Comes down, up, and down. That's supposed to be our normal QRS. But if there's an extra one, so we're going to have two of them back to back, or it's misshaped like this one is right now, or maybe inverted. Then it doesn't even come after the P, it may come after the T. Then we know it's a PVC or an extrasystole. So each of these things means something else. An enlarged Q, a Q wave. So we know the Q wave comes down slightly, but if it's too wide, then it goes up. Then we know we have an MI. If our R wave is extremely wide, like this one here, then we know it's an atrial ventricular hypertrophy. Then if we have an abnormal T wave, which you know is just supposed to be a little hill, a little mound, then we know it's flattened out hypoxia, elevated with an excess of potassium ions. Everybody means something. Everything, each of those structures there means something, okay? Alright, so a cardiac cycle consists of one complete contraction and relaxation of all four of the chambers. We have atrial systole. Get rid of my pen. We have atrial systole, which is dealing with contraction of the atria. And while this is contracting, the ventricles are relaxed, which is diastole. When we have atrial diastole, which is our contraction, our ventricles are relaxed. Quiescent period is when all of the chambers are relaxed at the same time. So this is a very brief moment when everybody's relaxed, and that is between the T or the U. Well, if there's a U between the T and the P's, a slight little relaxation right in there that occurs, and everybody starts working again. Now, certain principles of pressure and flow apply to movement of a fluid. A fluid is a state of matter that can flow in bulk from place to place, including both liquids and gases. Now, fluid dynamics is a term for principles that govern flow. And the main variables are pressures. The main variables are pressure, which impels a fluid to move, and resistance, which opposes the flow. Now, pressure is measured by a device called a manometer. I'm supposed to have a diagram here, but you guys should know what a manometer is, and it's typically a J-shaped glass tube, partially filled with mercury, and the sealed end above the mercury, it contains a vacuum, and the lower end is open, and then pressure applied at the lower end is measured in terms of how high it can push the mercury volume up the tube, and these pressures are expressed in millimeters of mercury. And that's what this symbol means, millimeters of mercury. Now, blood pressure is usually measured with a sphygmomanometer, which we've already seen, that the regular blood pressure cuff with the inflatable pressure cuff. Now, which has it's open and attached to an inflatable pressure cuff that is wrapped around the arm. Now, flow occurs when a fluid, Fluid occurs when a fluid is subjected to more pressure at one point than at another, which creates a pressure gradient. Now, fluid always flows down their pressure gradient. Now, an analogy that demonstrates this is what we see right here in figure 19.18. Now, this pressure is inversely proportional to the volume of the container. Now, as the plunger of the syringe is pulled back, the volume of the container, the volume inside, starts to increase. And what it would do, it would start lowering the air pressure in the barrel and pulling in the air from outside. Now, as the plunger is depressed, the volume decreases, raising the pressure in the barrel and forcing the air out. Now, a heart chamber, such as the left ventricle, is like a syringe barrel. It's just like a syringe barrel. Now, when the ventricle is expanding, pressure starts to fall. So here we have these are expanding, pressure is falling, and the blood flows into the ventricles. Okay, so here it is, into the ventricles. Then when the ventricles contract, the pressure rises, which you see in this particular one. The pressure rises, and when the aortic valves open, blood is ejected into the aorta. Now, the opening and closing of the heart valves are governed by pressure changes, since they have no muscle and are passive. Now, when the ventricles are relaxed, the AV valve cuffs hang down limply, and both valves are open. Now, blood flows freely into the ventricles even before the atria contracts. As the ventricles fill with blood, the cuspids float upward toward the closed position. When the ventricles contract, their internal pressure rises sharply, and it pushes the cuspids of the AV valves together to seal the openings. The papillary muscles, they will contract slightly before the rest of the ventricular myocardium, pulling on the tendinous cords and preventing the valves from bulging into the atria. Now, the rising pressure also opens the aortic and the pulmonary valves. Pressure in the aortic and the pulmonary valves, they oppose the opening. But when ventricular pressure exceeds atrial pressure, the valves open. Now, as the ventricles relax, atrial blood briefly flows backward and fills the cup-like cusp of the semilunar valves, sealing the opening. Now, here are a few of the insufficient disorders dealing with the valves. Now, the valvular insufficiency or incompetence is any failure of a valve to prevent reflux, which is regurgitation, which is like dealing with the backflow of blood. We have valvular stenosis, where the cuffs are stiffened and opening is restricted by scar tissue, and it results from autoimmune attack on the mitral, on the aortic valves, or the heart overworks and may become enlarged. Then we have a heart murmur, which is, we've heard of heart murmur before, an abnormal heart sound produced by regurgitation of blood through incompetent valves. Then we have our mitral valve prolapse, which hopefully everybody has heard of. I assume that has heard of, and it deals with the insufficiency in which one or both mitral valve cusps bulge into the atria during ventricular contraction, and hereditary in approximately 1 out of 40 people, and may cause chest pain and shortness of breath. Now, these different heart sounds that we have. 2 of 3 heart sounds are audible with a stethoscope during the cardiac cycle. When we do with auscultation, that deals with listening to sounds made by the body. Let me pull up everything for you guys. Now, listening. Now, the first sound, which is our S1, is that very first heart sound, and that's what describes our lub. Now, with S1 louder and longer, and S2 deals with our second sound. So we have our lub-dub, lub-dub. The first one, the S1, it occurs with the closure of the AV valves, turbulence in the bloodstream, and movements of the heart wall. Our S2, it occurs with the closure of the semilunar valves. Remember the semilunar valves? Remember the difference between the two, but it's the closure of the semilunar valves and turbulence in the bloodstream and movements of the heart wall. So our AV valves, hope you guys remember, AV valves are what? The mitral valve and the tricuspid valves. Our semilunar valves are our pulmonary valve and our aortic valve. Oops. Then our S3, if we will go back, our S3, here we go, I'm sorry. Our S3 is rarely heard in people over the age of 30. Now, in infants and adolescents, this is pretty normal to hear that third heart sound. But if it is heard in people older than 30, it's said to have a triple rhythm or a gallop. Now, the cause of each sound is not known with certainty because the valves operate silently. So turbulence in the blood flow may be the cause. Now, the cardiac cycle can be described as having 4 cycles or 4 phases, all of which are completed in less than 1 second. We have ventricular filling, isovolumetric contraction, and ventricular ejection, and isovolumetric relaxation. And all of the cycles occur within that 1 second. Now, when we deal with ventricular filling, now this deals with the relaxation of the ventricles. And when they relax, you have an expand. It relaxes and expands during diastole. Now, the AV valves will also open. Ventricular filling occurs in 3 phases. That is, the first one is rapid ventricular filling. It's in the first 1/3 when blood enters quickly. Then we have diastasis, is the second 1/3 and is marked by slower filling. The P wave of the EKG occurs at the end of the diastasis as the atrium depolarizes. And the third one is atrial systole, and it's the last 1/3 during which the atria contract and the filling of the ventricles are complete. Now, at the end of the ventricular filling, each ventricle contains an end diastolic volume of about 130 milliliters of blood. Only 40 milliliters, 31%, is contributed to atrial systole. So basically, this is the amount of blood that is remaining in the blood at the end of the contraction, end of the relaxation. So after the blood is filled into the ventricles, this is the amount of blood, this is the volume amount of blood that is within those ventricles, and it's called end diastolic contraction. So let's move on to the second phase of this cardiac cycle. We have isovolumetric contraction. The atria repolarizes, it relaxes, and then remain in a diastole for the rest of the cardiac cycle. The ventricles will then depolarize and generate this QRS complex and begin to contract, and pressure rises sharply. Now, the AV valves, they close, and the heart sound S1, which is our lub, it occurs, produced mainly by the left ventricle. And this phase, of course, is called the isovolumetric contraction, because even though the ventricles contract, they do not eject blood yet. There is no change in their volume. Pressure in the atria, in the aorta, which is about 80, let's see what's over here, yep, which is about 80 millimeters of mercury, and the pulmonary trunk, which has approximately 10 millimeters of mercury, are still greater than the pressures in the ventricles, with all four valves closed, and the blood cannot go anywhere. So after that, we have our ventricular ejection of the blood, and this begins when the ventricular pressure exceeds the atrial pressure. So there's more pressure in the ventricles than there are in the atrium, and that's what forces the let me pull this up. When it forces the semilunar valves to open. Now the pressure peaks at about 120 millimeters of mercury in the left ventricle, and 25 millimeters of mercury in the right ventricle. Now, why is that? Of course, it has to do with where this blood is going. You know, the left ventricle is going to be sending the blood where? To the remaining parts of the body, the upper extremity, lower extremity, and the organs, and then the right is pumping it where? Just to the lungs. So it doesn't need to, the pressure doesn't have to be that high to get to the lungs. It's just there. Now, blood squirts out rapidly at first, which is that rapid ejection, and then flows more slowly, called that reduced ejection. Now, ventricular ejection lasts about 200 to 250 milliseconds, corresponding to the plateau of the myocardial action potential, but lagging somewhat. Now, the T wave occurs late in this phase. Let's see if I have any more. Okay, yep. Now the T wave occurs very late in this phase, and the ventricles do not expel all of the blood. Now each ventricle in an average resting heart contains an EDV, which is our end diastolic volume, of 130 milliliters. Now, the amount ejected is about 170 milliliters. So that's our stroke volume. So that's the amount of volume that is amount of blood that's being ejected from the blood. That is stroke volume. Okay. Now the percentage of the EDV ejected is about 54%, and that's the ejection fraction. Now the blood remaining behind is about 60 milliliters, and is termed the end systolic volume. So that's the rest of blood that's staying inside of the heart. Come on. Think about the recoiling. Okay. Hold on a second. Okay, so this is onto my other slide, which should not be there. But with vigorous exercise, let me pause. Okay, I'm going to go back to that one slide. Okay, so this one here where we talked about the ejection fraction and the end systolic volume, which is the amount of blood that's left inside the ventricles after the blood's been ejected out. We already know that with vigorous exercise, the ejection fraction may be as high as 90%. Now, a diseased heart may eject much less than 50%. So this fourth phase, I think we're on number 4. Yep, we're on number 4. With this fourth phase, the isovolumetric relaxation, this occurs when the T wave ends and the ventricles begin to expand. Now we have two hypotheses that try to explain this whole ventricular expansion. Now, one is that the blood flowing into the ventricles inflates them, and the other is that the contraction of the ventricles deforms the fibrous skeleton, which spreads them and sucking blood into the ventricles. Now, at the beginning of ventricular diastole, blood briefly flows backward through the through the semilunar valves. Now, this backward flow, it quickly fills the cuffs and closes them, creating a slight pressure beyond or pressure rebound that appears as a diacritic notch of the aortic pressure curve. Now, if the heart sounds S, which is our dove, occurs as blood rebounds from the closed semilunar valves, and the, not if it sounds, but the heart sounds S, which is our dove. It occurs as blood rebounds from the closed semilunar valves and the ventricle expands. Now, this phase is called the isovolumetric, and that's because the semilunar valves are closed. The AV valves have not yet opened, and the ventricles are therefore taking in no blood. Now, when the AV valves open, phase 1 begins again, and the heart sounds S. Now the heart sounds S3. If it occurs, it is thought to occur from the transition from expansion of empty ventricles to their sudden filling with blood. Now, in a resting person, atrial asystole, it lasts about 0.1 second. Now, the ventricular asystole is approximately 0.3 seconds, and the quiescent period is 0.4 seconds. A total duration, therefore, is 0.8 seconds in the heart, beating at 75 beats per minute. All right, so when we look at the different changes during a cardiac cycle, we're going to look at it from this view. Okay, so about our end systolic volume. What did we say was the end systolic volume? Hope you guys remember. I was paying attention. Okay, sorry about that. Our end systolic volume, hope you guys remember that, is equal to about 60 milliliters. Now, passively added to the ventricle during atrial diastole, which is the positive 30 milliliters. And then we add that to our atrial systole, which is 40 milliliters. So when we add up, we have our total diastolic volume, our end diastolic volume of 130. So remember, end diastolic volume is what? Hopefully you guys remember. Is the amount of blood that is in the ventricles after they're filled. When the ventricles are filled, this is the amount of blood that's in there. Okay? So when the ventricles contract and they release all that blood, release the blood out, they release approximately, or they eject 70 milliliters of blood, leaving back that 60 milliliters of blood in the heart. So start again. We have our end systolic volume. Our end systolic volume is what the ventricles, the amount of blood that remain in the ventricles after they have contracted. Now there's passively adding of, there's blood that's added into the ventricles during the assisted atrial diastole and as well as systole, which gives us our 130. Then when it's ready to eject blood again, it is 70 milliliters that is ejected, called our stroke volume, and that will leave back our 60 milliliters of blood. Now both ventricles must eject at the same time. Now we have in the blood, this is another overview of the volume changes. Now in the left ventricle is pumped out. If the left ventricle pumped out more blood would accumulate in this systemic system and cause hypertension and edema there. Now if we have fluid accumulation in either of the circuits due to ventricular pumping insufficiency, it will cause congestive heart failure. So we look at congestive heart failure. What is that? Results from the failure of either ventricle to eject blood effectively. Now, usually due to heart weakness or heart weakened by myocardial infarction or MI, or chronic hypertension, or valvular insufficiency, or congenital defects in heart structure. So that's what's occurred during birth. If a child's heart did not develop properly during the growing stages within the womb, that's called congenital defects. We have left ventricular failure, and that blood backs up into the lungs, causing pulmonary edema, shortness of breath, and then a sense of suffocation. And then within the right ventricle failure, this is where blood backs up into the vena cava, causing systemic or generalized edema, enlargement of the liver, ascites, distension of the jugular veins, and we'll have swelling of fingers, ankles, and feet. There's a few things that will occur. Now, the eventually leads to total heart failure. So this is the end of our second part 2 of 3.